Hi, everyone, and welcome to our module on tubulointerstitial disorders. We'll begin by talking about acute renal injury. This is a term that refers to an acute fall in the glomerular filtration rate and a rise in the serum levels of BUN and creatinine. It's usually reversible, and it's a very, very common problem among hospitalized patients. When you do your clinical rotations, you will see many patients with acute renal injury. And there are basically two causes. The first cause is poor renal perfusion. The kidneys are healthy, but there's a fall in GFR because not enough blood flow is reaching the kidneys. And then the second cause is acute tubular necrosis, and that's what we'll talk about now. Acute tubular necrosis refers to sudden damage to tubular epithelial cells. There are a number of reasons this can happen. First of all, this can happen from ischemia. Any cause of severely decreased blood flow can lead to tubular necrosis. So basically, if you have a mild fall in blood flow to the kidneys, you will see pre-renal failure where the BUN and creatinine will go up, but the kidney cells remain healthy and intact. If, on the other hand, the decrease in blood flow is severe, then those cells begin to die, and that's acute tubular necrosis. Besides ischemia, there are also a number of drugs which have kidney toxic side effects, and there are also a number of toxins, and these things can also lead to acute tubular necrosis. Let's talk about ischemic ATN in a little bit more detail. When there is ischemia to the kidneys, this leads to vasoconstriction. It's high yield to remember this. Vasoconstriction of blood vessels that supply the glomeruli with blood flow, and this leads to a severe drop in GFR in addition to necrosis of tubular cells. The reason that vasoconstriction occurs is because there is loss of tubular cell polarity. Let's talk about what that means now. At the bottom of the screen is my own drawing of a tubular epithelial cell, and I talk about how these cells work in great detail in the video on nephron physiology. But many of these cells have a sodium-potassium ATPase on one side of the cell, and this is what drives the reabsorption of solutes. In the setting of ischemia, this sodium-potassium ATPase moves to the other side. It moves to the luminal side where it begins to pump sodium into the urine. This is the opposite of what it is supposed to do under normal circumstances. This leads to more sodium in the luminal side, and that sodium will travel down the lumen of the nephron, and it will be sensed by the macula densa, and then the macula densa will do what it normally does as part of tubuloglomerular feedback. It will trigger vasoconstriction. So by this mechanism, when you get ischemia, not only do you get death of tubular epithelial cells, but you get this sodium-potassium ATPase pumping more sodium into the urine, and that leads to vasoconstriction, which makes the whole problem worse. On this side, I've listed some of the causes of ischemic ATN, basically any cause of decreased perfusion. This could be hypovolemia from vomiting or diarrhea. This could be cardiogenic shock. It could be hemorrhage. Anything that lowers the perfusion to the kidneys can lead to tubular necrosis. Some of the toxins and drugs that can cause tubular necrosis are listed on this slide. So aminoglycosides are famous as antibiotics that have renal toxic side effects, and they can cause ATN. Contrast dye that's administered for CT scans can cause ischemic ATN. Uric acid pours out of cells in the tumor lysis syndrome, and this can cause ATN. And rhabdomyolysis also has myoglobin spilling into the plasma, and this can lead to ATN. Lead and cisplatin, which is a chemotherapy agent, are famous for causing ATN. And then finally, ethylene glycol, which is an antifreeze. If people drink this as part of a suicide attempt, they can get ischemic ATN in addition to a anion gap metabolic acidosis. In tubular necrosis, the epithelial cells die and they slough off into the urine, and they obstruct urine flow through the nephron. And this leads to intrinsic renal failure. I talk about different types of renal failure in another video, but ATN is a form of intrinsic renal failure. The GFR will fall and the BUN and creatinine will rise. You will also see evidence of epithelial cells in the tubules when you examine the urine. So the epithelial cells form casts as they move through the tubules, and you can see these if you examine the urine of a patient with ATN. They're described as granular casts or muddy brown casts, and this is a picture of one shown on the slide here. We don't usually do renal biopsies among patients with ATN, but if you did, what you would see is patchy focal necrosis of the nephron. And it's important to remember that it's patchy with these large skip areas of normal nephron. They like you to know that kind of thing for your exams. You can also see occlusion of the tubular lumen by casts. In addition, you should be aware, and it's very high yield to remember this, that ischemic injury and toxic injury affect different portions of the nephron. Ischemic injury affects the proximal tubule and the thick ascending limb, while toxic injury affects only the proximal tubule. Here's a drawing of the nephron indicating the portions affected by ischemic ATN. So the idea here is that there are lots of sodium-potassium ATPases in the proximal tubule and in the thick ascending limb. So when there's ischemia and there's lack of oxygen, These are the areas of the nephron that are most affected. In contrast, toxic ATN usually affects only the proximal tubule, and the reason for this is because those toxins are filtered, and the first thing that they encounter is the proximal tubule, so that's where they usually exert their damage. There are three phases to ATN, and what the kidneys do in each phase is a little bit different. Phase one is when the injury occurs, so there's ischemia or injury from a drug or toxin, and there's a slight decline in urine output. Phase two is called the maintenance phase. This is the longest phase of ATN. There's oliguria, there's a rise in the serum BUN and creatinine, and importantly, in this phase, patients can potentially die from life-threatening hyperkalemia. In addition, there's an anion gap metabolic acidosis that occurs in this phase, and this may last several weeks. This is followed by the recovery phase, and when the kidneys begin to recover, they pour out urine. So patients in this phase have polyuria, and in contrast to phase two, the risk here is hypokalemia. There's so much urine output that potassium can be lost in the urine, and hypokalemia may develop. So it's very high yield for your boards to remember that there are three phases, and in phase two, there's low urine output and hyperkalemia. In phase three, there's high urine output and hypokalemia. The prognosis for ATN is generally good. The typical course is kidney recovery. Tubular cells are capable of regeneration. The kidneys and the nephrons can undergo a process called tubular reepithelialization, and this is why the kidney function usually recovers. There are some patients who require temporary dialysis, especially during that maintenance phase, to keep their levels of potassium normal. Moving on, let's talk about acute interstitial nephritis, which is also sometimes called tubulointerstitial nephritis. As the name implies, this is inflammation. That's why it's called nephritis. And the inflammation involves the renal tubules and the interstitium. The interstitium is the space between cells in the kidneys. This is a hypersensitivity or allergic reaction that is mediated by eosinophils and neutrophils. It's usually a response to a drug, and we'll talk about some of the typical drugs, although sometimes it's a response to an infection or an autoimmune disease, and it usually resolves if you stop the offending agent, especially if it's caused by a drug. The main clinical feature is intrinsic renal failure. There's a rise in the BUN and creatinine and a fall in urine output. Importantly, there's absence of the nephritic or nephrotic syndrome. When any of these things are present, then it's considered a glomerular disease. What makes something interstitial nephritis and not a glomerular disease is the fact that there's no evidence of nephritic or nephrotic syndrome, just isolated renal failure. Drugs are the most common cause of interstitial nephritis. They cause about 75% of cases. Some of the drugs that classically do this are listed on this slide. Sulfonamides can do this. Rifampin and penicillins may cause interstitial nephritis. Some diuretics may cause interstitial nephritis, like furosemide, bumetanide, and thiazides. And then finally, nonsteroidal anti-inflammatory drugs can cause acute interstitial nephritis. The mechanism by which these drugs cause nephritis is often by acting as a hapten. I talk about haptens in the immunology section. They are molecules that elicit an immune response when they are bound to tissues or cells. And in many cases, these drugs attach to the basement membranes or to tubular epithelial cells, and they trigger an immune response. Other causes are shown in the screen. About 10% of cases are associated with infection. There are many organisms that have been reported. Some of the ones that are common are Legionella, Leptospira, CMV, or tuberculosis. And then finally, systemic diseases also account for a small number of cases. Interstitial nephritis has been associated with sarcoidosis, Sjogren's syndrome, and lupus. So let's talk about some of the classic findings that a patient with interstitial nephritis will have when they present for evaluation. First of all, that patient will have been exposed to a trigger sometime in the last few days or weeks before they got sick. Usually it's going to be one of the drugs we talked about. They will then have evidence of inflammation and an allergic reaction. So they might have a fever, they could have a rash, and they'll have malaise. On serum blood testing, you will see evidence of acute renal failure with a rise in the BUN and creatinine. When you examine the urine, you may see white blood cell casts, but importantly, you will see them without evidence of cystitis, and this is a very important point. Shown on the screen is a white blood cell cast, and I talk about these in the urinary tract infection video because they're the hallmark of a UTI. But you can also see white blood cell casts in interstitial nephritis because there are white cells involved in this process as well. Importantly, a patient with interstitial nephritis will not have burning or dysuria or any evidence of cystitis. Those things are only seen with infection. So if you see a case describing white blood cell casts with no evidence of dysuria or cystitis, you should think of interstitial nephritis. This is called sterile pyuria because there are white cells in the urine, but there's no bacteria. Now also, because it's an allergic reaction, there may be peripheral eosinophilia, and sometimes you can also see eosinophils in the urine. As I told you before, this is usually a benign disorder. The symptoms resolve with stopping the offending agent, but in rare circumstances, it can progress to something called papillary necrosis, and we're going to talk about that a little bit later on in this video. There is a chronic form of interstitial nephritis. This involves mononuclear cells, and it leads to fibrosis and atrophy of the tubules. This is seen only among patients with long-standing use of high levels of nonsteroidal anti-inflammatory drugs. So in a board question, this is always going to be someone who's got some type of joint pain or other condition and takes lots of NSAIDs every day. There will be a mild elevation of the BUN and creatinine. It will resolve with stopping the drug. So the classic case is a patient on chronic NSAIDs for chronic pain with a mildly elevated BUN and creatinine, and the renal function improves with stoppage of the drug. That patient likely has chronic interstitial nephritis. Let's pause and talk about NSAIDs for a minute because these drugs are associated with a number of different kidney problems. As I mentioned earlier, NSAIDs can cause acute interstitial nephritis. This is an acute allergic reaction to the drug, so it will present with fever, potentially a rash, and evidence of renal failure. NSAIDs can also cause chronic interstitial nephritis, so these patients will not have fever or rash or anything like that. They will simply have renal failure. They're usually asymptomatic, and this is usually picked up on incidental blood work. And what's going on is a chronic inflammation in the kidneys related to NSAIDs. NSAIDs can also potentially cause acute tubular necrosis. This is because they can lead to ischemia. NSAIDs block prostaglandin-induced vasodilation of the afferent arterioles, and this can lead to ischemia. NSAIDs are also associated with membranous glomerulonephritis. This is a cause of the nephrotic syndrome, which I talk about in another video. And then finally, NSAIDs are associated with papillary necrosis, so let's talk about that now. Papillary necrosis refers to coagulative necrosis of the renal papillae. The renal papillae are this portion of the kidney that I'm marking with my pen. This is where the pyramids empty urine into the collecting system for passage on to the ureter. When this happens, this leads to sloughing of tissue and gross hematuria that is often painless. And the word gross is very important here. So often when we talk about hematuria in kidney diseases, we're talking about microscopic hematuria that you only see with the microscope. The situation is different in papillary necrosis because you have sloughing off of large pieces of tissue. Patients will report that they see clumps of blood in their urine. That's very unusual. That's gross hematuria, and that's what you see in papillary necrosis. Also important to understand is that when this occurs in isolation, there's no intrinsic renal failure or white blood cell cast. That's because the glomeruli and the tubulars are not found in the papillae. So when you have damage to this area in isolation, the kidney function remains intact. Now, you can get renal failure in papillary necrosis. That's because the tissue that sloughs off may obstruct urine flow, but you shouldn't see intrinsic renal failure like you do in glomerular diseases or tubular necrosis because those portions of the nephron remain intact. Some of the classic causes are shown on the slide here. Phenacetin is a drug no longer on the market. It used to be used for pain control, but it led to some tumors and kidney failure. Tylenol is a phenacetin derivative, which is still used today. Diabetes can also cause this. This can be a consequence of acute pyelonephritis. And then finally, the most important cause to remember in terms of your boards is sickle cell anemia. This often leads to papillary necrosis. So the typical presentation is a patient with one of the typical triggers, gross hematuria that is painless, and normal renal function. This is papillary necrosis. I'll finish with this slide and discuss cortical necrosis. This is caused by ischemia of the renal cortex, and it presents as the acute onset of severe renal failure. Remember, in the renal cortex is where you find the glomeruli, so if they are damaged, you will not filter any blood and you will not make any urine, and that will lead to severe renal failure. This is only seen among very sick patients. It can be seen in patients with septic shock. It's also classically associated with obstetric catastrophes, especially placental abruption or fetal demise. It presents as acute renal failure with severe oliguria, usually leading to anuria, meaning no urine output. And once again, that's because in the cortex you find the glomeruli, so if you destroy your glomeruli, you're not going to make any more urine. And that concludes our video on tubulointerstitial disorders.